Hi everyone, on today's podcast, we're going to talk about the evidence on Group B Strep during pregnancy. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See evbirth.com/disclaimer for more details. Hi everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. My name is Dr. Rebecca Decker, pronouns she, her, and I'll be your teacher for today's episode. Today, I'm so excited to bring you some brand new evidence-based information to you about Group B Strep during pregnancy. This is the first EBB podcast episode where we're focusing on Group B Strep, and we're doing this in anticipation of the launch of our signature article on Group B Strep, which will be updated in the next few weeks. Our original signature article on GBS was published back in 2014 and last updated in 2017. So today I'm sharing with you the result of doing a ton of research and preparation for the 2023 update. So this episode is part one of a two-part series. In today's part one, we're going to talk about the evidence on Group B Strep during pregnancy, the evidence on testing for GBS, and the evidence on antibiotics, including the pros and cons of giving antibiotics during labor for Group B Strep. In part two, which will come out in episode 257, airing on March 1st, 2023, we'll switch gears a little bit and talk about the evidence on alternative treatments for Group B Strep, and we'll also answer a ton of your questions at that time. Before we get started, I wanted to let you know that in today's podcast, we will discuss GBS-related stillbirth, infant death, the critical illness of newborns, and disparities in access to healthcare. Also, heads up, Group B Strep is a controversial topic. And ever since I first started writing about Group B Strep for the public in 2014, I became aware of the fact that some people can become really upset and even angry with me when I talk about the evidence on GBS. So if at any point you start feeling your heart rate go up, your breathing shift, or you feel foggy or intensely emotional, please use this as a sign that you can turn inward to process your emotions and not outward to lash out at me or our team here at Evidence-Based Birth. Our role here at EBB is to provide information, not judgment. So please try to separate the information I'm presenting today from your emotional response. You can learn more about how to disagree respectfully on birth topics at Evidence-Based Birth episode 87, our interview with Kristen Pascucci. Also, please understand that there is a lot of misinformation online about GBS. I'm coming to this podcast with you to share what I've learned after 9 years of reading and critically analyzing the research on this topic. I bring this information in service to you all, and I hope that it is helpful. As a side note, my team and I will not be answering email questions about this topic. And that's because in part two of this episode, which airs on March 1st, we're going to go into depth and answer the most frequently asked questions about this topic. At that time, we will also have a free one-page handout that you can download, as well as the full-length signature article with all of the research references so you can go check out all of the studies for yourself. You might want to sign up for our email newsletter at evidencebasedbirth.com so that you can be notified as soon as the free handout on Group B Strep is available. If you're listening to this after March 1st, 2023, you can go on to ebirth.com/Group B Strep, that's all lowercase, all one word, /Group B Strep, to access the entire full text of the Group B Strep signature article along with the free one-page handout. Also, if your questions are not answered, after listening to part one and part two, we do have a section of our community inside the EBB Pro membership where our members can ask myself and the research team direct questions about the research, and you can learn more about that at ebirth.com/membership. So today in part one, I'm going to give a brief overview or introduction to the subject, and then we'll get into all the details about Group B Strep, the microbiome, antibiotics for Group B Strep, testing for Group B Strep, the research on antibiotics, and more. Are you ready to get started? All right, let's go. First, a brief overview on this topic. In some countries, pregnant people are tested for Group B streptococcus, often called Group B Strep or GBS. This is a bacteria they're tested for towards the end of pregnancy. If someone is a carrier of Group B Strep, They're sometimes called being colonized with GBS. If they're a carrier of GBS and not treated with appropriate antibiotics during labor, then there is a 1 to 2% chance that their baby will develop early GBS disease. Early GBS disease is a serious illness in the first week of life that can result in long and expensive stays in newborn intensive care units or NICUs. Group B Strep was first recognized as a widespread threat to newborns in the early 1970s, so more than 50 years ago. At that time, almost 2 out of every 1,000 infants born in the United States had early GBS disease. Today, because of a major public health campaign called Universal Screening, which we'll talk about more in depth later, early GBS disease in infants is rare in the United States, but it's still a leading cause of newborn illness and death in other places around the world. As I said earlier, the topic of Group B Strep can be quite controversial. In high-resource countries where some people face excessive medical care and overuse of interventions, using preventive antibiotics for the 1/3 of people who have a positive GBS test, when it will not lead to illness for 98 to 99% of their infants, can be seen as unnecessary by some. They may have legitimate concerns about the overuse of antibiotics and the negative effect of antibiotics on a baby's microbiome. Meanwhile, some healthcare workers may get frustrated when parents who are GBS positive decline antibiotics because if one facility sees thousands of births per year, a 1 to 2% chance, which might seem low to individual parents, could then translate into dozens of sick babies who need intensive care in that 1 year alone. Meanwhile, in other places around the world, or sometimes even within high-resource countries, marginalized groups of people are not provided basic healthcare options, such as accurate testing for Group B Strep, IV antibiotics, or medical help when they or their infants experience serious illness or complications. In those places, and particularly low-resource places, GBS is still a leading cause of newborn death. So, what is Group B Strep, and why do healthcare workers worry about newborn GBS disease? Does the evidence support testing for GBS and giving IV antibiotics during labor to prevent newborn infections? What are the benefits and risks of IV antibiotics during labor? And what is the microbiome that I've been mentioning, and how is it impacted by antibiotics during labor? So today, I'm going to provide you with a global perspective on Group B Strep, as well as an explanation of how GBS and antibiotics interrelate with the microbiome. So that was a brief overview of the topic for you. Now let's get into some details. What is Group B Strep? Group B Strep is a type of bacteria that naturally lives in the large intestine and can migrate down to the rectum, vagina, and urinary tract, usually without causing illness. All around the world, around 18% of pregnant people carry GBS in their bodies. However, carrier rates can be as low as 8% or as high as 35%, depending on the part of the world that you live in and how common GBS is in the bodies of people living there. During most of your life, if you carry GBS, it's considered physiological or normal. However, GBS can cause infections during time periods when your immune system is not functioning at its highest, such as when you're very young, or you're very old, or you have a chronic illness. And these infections with GBS are called GBS disease. In pregnancy, GBS can sometimes lead to urinary tract infections, preterm birth, and stillbirth. However, it is somewhat uncommon for GBS to cause disease in pregnant people. It is the cause of only about 1 to 2% of urinary tract infections and only about 1 to 2% of all stillbirths. For newborn babies, though, whose immune system is not yet mature, GBS can cause a serious disease that usually requires a stay in the NICU. There are 2 main types of GBS disease in new babies. Early onset GBS disease, which occurs during less than 7 days of life, and late onset GBS disease, which occurs 1 week through 3 months of life. Some newborns can also be carriers of GBS as well, but not develop sickness. So in this podcast episode, we're going to be focusing on early onset GBS disease during that first 0 to 6 days of life. To prevent early GBS disease in newborns, countries around the world generally choose 1 or the other approach. There's two main approaches. One is the universal screening approach. This is where you screen everyone who's pregnant for GBS at 35 to 37 weeks. In the US, this was recently changed to 36 to 37 weeks. And then everyone who tests positive is treated with appropriate antibiotics during labor. This is the method that is currently recommended by the World Health Organization, and it's also used in 60 countries, including the US, Canada, Mexico, Brazil, Chile, Argentina, Uruguay, France, Germany, Spain, Australia, Japan, and more. The second common approach is called the other risk factor approach. In these places, pregnant people are not screened for GBS. Instead, those in labor are treated with antibiotics if they have one or more of these other risk factors, including GBS detected in the urine at any point during pregnancy, someone previously gave birth to a baby with early GBS disease. Both of those are signs of heavy colonization or heavy presence of GBS, going into preterm labor, having a fever during labor, or your water has been broken for more than 18 hours. Now, the specific other risk factors that are chosen may vary slightly from country to country, but the other risk factor approach is currently used in 25 countries, including the United Kingdom, Ireland, the Netherlands, Norway, Sweden, Finland, Saudi Arabia, South Africa, India, Thailand, the Philippines, and New Zealand, among others. Later on this podcast, I'm going to talk about which approach is most supported by evidence, the universal screening approach or the other risk factor approach. But first, let's take a step back and talk about the microbiome and how it works in the human body. What is the microbiome? The microbiome is the ecosystem of trillions of microbes, bacteria, fungi, protozoa, and viruses that live and coexist with you in certain places in your body, such as on your skin or in your gut, your nose, mouth, and genital and urinary tracts. The different types of bacteria that make up your microbiome can have good, neutral, or negative impacts on your body. The microbes that have good effects are called beneficial bacteria or probiotics. Probiotics are like invisible workers that positively influence countless aspects of your body, many that are still unknown. But the ones that we know about include energy, digestion of food, brain activity, including your behavior and your emotions, how you metabolize drugs, how you release and synthesize essential vitamins, protection against infection, and more. Your microbiome gets its start before you were born. Researchers have found that fetuses swallow tiny amounts of maternal gut bacteria floating in the fetal amniotic fluid, in other words, the waters inside your amniotic sac. But the bulk of your microbiome is seeded when you were born, seeded spelled S-E-E-D-E-D. When you're exposed to the first time to your birthing parents' genital tract and or skin. In fact, one reason that newborns born by vaginal birth tend to have better health outcomes in infancy and childhood is because a microbiome seeded by vaginal birth tends to have more beneficial bacteria at a young age when your immune system is developing than a microbiome seeded by a cesarean birth. Some people who give birth by cesarean may attempt to replicate the microbiome received from a vaginal birth by wiping their baby's mouth, face, and skin with the birthing person's vaginal fluids. This is a practice known as vaginal seeding. Vaginal seeding is controversial, and I'm not going to cover it anymore in this podcast, but you can learn more about it at a link I'll supply in the show notes. Infant feeding methods also have a strong influence on the microbiome. Human milk contains antibodies or immune properties that fight bad bacteria and prevent it from finding a permanent home in the gut. Human milk also contains large amounts of oligosaccharides. These are complex sugars that feed the beneficial bacteria. By boosting the probiotics, the oligosaccharides also positively influence a body-fed newborn's immune system and their ability to fight infections. Now, the microbiome is constantly changing in the first 3 years of life as you have close contact with new people, places, animals, foods, and fluids. After about 3 years of age, your microbiome stabilizes, and the bulk of it will remain the same throughout adulthood except when you experience infections or if you have close contact with different types of bacteria. Some people who are not carriers of GBS in childhood may become GBS positive later in life through close or intimate contact with other people. However, Group B Strep is not considered a sexually transmitted infection for two main reasons. Number one, it's a naturally occurring bacteria. It's present in the bodies of many people who are not sexually active. And two, it rarely causes infection or problems unless you're a newborn, elderly, or immunosuppressed. Group B Strep can join your body's microbiome, though, if you have close contact with someone else who carries GBS. Just like how other bacteria could be introduced into your microbiome through close contact with others. There is no evidence, however, that GBS is spread by water, food, or surfaces. So what causes early Group B Strep disease in babies? Right before a baby is born, the microbiome has not yet been seeded. And so there is a window of opportunity for bad bacteria to gain a foothold in the fetus's body. Fortunately, there are many ways that the fetus is protected from infection during pregnancy. One major protective factor is the chorioamnion, also known as the fetal membranes. This is the bag or sac surrounding the waters. The membranes are a very important barrier that prevent bacteria from getting into the uterus and the fetus. However, once the membranes rupture, also known as your water breaking, there is now a potential pathway for infection to occur. Group B Strep bacteria, if present, could travel up from the vagina into the amniotic fluid in uterus in what is called an ascending infection or vertical transmission of bacteria. The fetus could then swallow some of the GBS bacteria, it could get into their lungs, and they could possibly experience early GBS disease. Early onset GBS disease is defined as detecting GBS in the blood, cerebrospinal fluid, or lungs, along with the infant showing signs of clinical disease including sepsis or bloodstream infection, meningitis, or pneumonia during days 0 through 6 of life. Now, when a baby has early GBS disease, symptoms appear at birth or shortly after birth. In almost all babies, about 95% will have symptoms within 48 hours. In one study of 94 infants who had early GBS disease, almost all of them were diagnosed within 1 hour after birth. And this is why researchers believe that GBS disease usually begins before birth, when the bacteria gets a foothold in the baby's body and begins to grow before they're born. Newborns can also become normal carriers of GBS when it meets their skin, nose, and mouth as they travel down the birth canal during a vaginal birth. However, most of these infants stay healthy and do not develop disease. So how common is early GBS disease in infants? So Seal et al. In 2017 published a meta-analysis where they combined data from many studies all around the world, and they estimate that out of 140 million live births in 2015, about 205,000 infants had early GBS disease. Researchers have studied GBS and found that if a birthing person who carries GBS is not treated with appropriate antibiotics during labor, the baby's risk of becoming also a carrier of GBS is about 50%, and the risk of early GBS disease in the infant is 1 to 2%. Now, as I said earlier, being a carrier of GBS is not the same thing as developing early GBS disease. Most of the carrier infants stay healthy. On the other hand, if the birthing person with GBS is treated with antibiotics during labor, the risk of the infant developing GBS disease in the early period drops by 80%. So, for example, the risk could drop from 1% down to 0.2%. In the United States, the Centers for Disease Control does run a program called the ABCs, where they actively track potentially invasive bacteria. They have a sample of 10 states covering a population of about 45 million people. In the early 1990s, before it was recommended that people in the United States be screened for GBS and treated with IV antibiotics during labor, there are about 1.8 cases of early GBS disease for every 1,000 live births. After some new recommendations went into action where they recommended screening everyone for GBS and giving antibiotics as appropriate, rates of early GBS disease in the United States dropped drastically. In the most recent data set from 2020, the ABC's program found that there were only 0.2 cases of early GBS disease for every 1,000 live births. In England, where the other risk factor approach is used to lower the risk of GBS disease, the 2020 rate of early GBS disease was 0.53 per 1,000 births, which is more than double the rate in the United States. So what is the risk of death with infant GBS disease? Researchers who studied global rates of GBS disease reported that in 2015, there were 51,000 deaths of infants with early GBS disease in places where there was no access to healthcare facilities. There were 27,000 GBS deaths due to early GBS disease in developing countries that have some access to healthcare facilities, and there were only 500 early GBS deaths in developed countries with reliable access to health facilities. When stillbirths from GBS, early GBS disease, and late onset GBS disease were combined, GBS was a leading cause of fetal and infant death around the world, causing more than 127,000 infant deaths and stillbirths each year. The burden of infant mortality from early GBS disease is borne disparately by low-resource countries. The countries with the highest numbers of annual deaths due to infant GBS disease include India, Nigeria, Ethiopia, the Democratic Republic of Congo, and Pakistan. In the year 2015, it was also estimated that in-labor antibiotics prevented about 29,000 cases of early GBS disease and prevented 3,000 early newborn deaths, mainly in high-resource countries that have access to this approach. If in-labor antibiotics were available worldwide, it's estimated that another 83,000 cases of early GBS disease and 27,000 infant deaths could be prevented each year. In the United States, which is considered a high-resource country by researchers, despite the high number of perinatal care deserts, about 7% of full-term infants with early GBS disease will still die from their infection. Death rates are higher, about 19% in preterm infants with early GBS disease. Although newborns in high-resource countries will most likely survive if they have early GBS disease, their illnesses are serious and usually require long, expensive stays in a NICU with many interventions that are used to treat complications from GBS-caused pneumonia, sepsis, or meningitis. In middle or high-resource countries, about 18% of infants who survive GBS-caused meningitis will end up with moderate to severe neurodevelopmental problems, including long-term cognitive, motor, vision, or hearing impairments. Rates of long-term neuro problems are likely much higher in low-resource areas of the world. Is it possible to identify which newborns are more likely to get early GBS disease? Well, the main risk factor for early GBS disease is when the birthing person is a carrier of GBS. However, there are some other factors that may increase the likelihood that a baby could have early GBS disease. Being born preterm has been linked with a higher risk of having early GBS disease, possibly because a GBS uterine infection can lead to a preterm birth in the first place. Next, a long time period, about 18 to 24 hours or longer, between when your water breaks and giving birth. Also, if the birthing person has a high temperature during labor, greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. And those three are the most important risk factors. Other risk factors include the waters broke before labor started, also known as premature rupture of membranes, having infection of the membranes of the uterus, also known as chorioamnionitis, having previously given birth to an infant with early GBS disease, experiencing intrauterine monitoring during labor or internal monitoring, having membrane stripping or membrane sweeping performed on you, having GBS in your urine at any point during pregnancy, and giving birth for the first time. However, about 60% of infants who develop early GBS disease have none of these other risk factors that I just listed for you, except for the fact that the birthing person is a carrier of GBS. So that is the main risk factor, and all the other ones are more minor risk factors. So how are you tested for GBS during pregnancy, and how accurate is the test? In their most recent guidelines, the American Congress of Obstetricians and Gynecologists recommended measuring GBS with a culture test at 36 to 37 weeks of pregnancy, not at 35 weeks, which used to be common. To collect the sample for the culture test, a swab that resembles a Q-tip will be used, a long Q-tip. The cotton tip should first be inserted into the vagina, not very far, only about 2 centimeters or 3/4 of an inch. And then again into the rectum, about 1 centimeter or a 1/2 inch through the anal sphincter. A speculum should not be used with this. After collecting the sample, the swab is placed in a special tube and sent to a laboratory for culture testing, where they see if the sample grows GBS bacteria. It takes about 48 hours to get these results back, and people with severe allergies to penicillin should also be getting additional results called susceptibility testing that describes whether the GBS they are carrying can be treated with alternative antibiotics. So when studying the accuracy of these tests, most researchers have compared the culture results at 35 or 36 weeks, which used to be the standard before it was changed to 37, to culture results from a sample collected during labor. A culture test during labor would be considered the gold standard because it's getting a picture of your GBS culture results at the time it's important. But because it takes 48 hours to get culture results back, taking a culture during labor is not used in practice. So in studies, though, they can still do it. They just don't have the results to guide how they treat you in labor. So because people can test positive for GBS consistently or temporarily, your results can change depending on how much or how little GBS is present in your gut. The goal is to get results within at least 5 weeks of giving birth, which should be a reliable sign of whether GBS will be present in your birth canal during labor. In one high-quality study done by Young et al. In 2011, researchers did the culture test twice in everyone. They did it once at 35 to 36 weeks and once again during labor. And then they compared these two results. Of all the pregnant people who screened negative for GBS at 35 to 36 weeks, 91% were still GBS negative when the culture was done again during labor. The other 9% converted to GBS positive during labor. These 9% were missed cases, meaning that they were carriers of GBS, but almost all of them did not receive any antibiotics. Of those who screened positive for GBS at 35 to 36 weeks, 84% were still GBS positive when the culture was taken again during labor. However, 16% of the GBS positive people converted to GBS negative by the time they went into labor. And these 16% likely received unnecessary antibiotics because the GBS was not present in the birth canal. So that is a little bit about testing. Now let's move on to antibiotics and how they work in the body. Antibiotics are medications that target and kill bacteria. Literally, they're antibiotics. Most people today take the existence of antibiotics for granted. However, before antibiotics became widely available, bacterial infections caused massive amounts of human suffering. For example, if you lived in the year 1900 in the United States, the average life expectancy was only 47 years old. That's because so many people died of bacterial diseases. The leading causes of death were pneumonia, tuberculosis, and bacterial diarrhea, which together with diphtheria, another bacteria, caused 1/3 of all deaths in the country. And 40% of these deaths were among children under the age of 5. Meningitis, which is considered a treatable disease today, used to be almost always fatal in children back then. Strep throat could lead to scarlet fever, which could cause heart damage and heart failure. And cesareans had a very high maternal mortality rate, sometimes as high as 90%, mainly because it was impossible to treat internal infections transmitted during the surgery. Now, many people claim that antibiotics were discovered in the 1920s. However, that narrative is false. For thousands of years, humans have been identifying and using antimicrobial agents that occur naturally in nature. The first written description of antibiotics was from a papyrus from Egypt dated 1500 BCE, where they described putting moldy bread on wounds, and that will make sense in a minute. Researchers have also found traces of tetracycline, an antibiotic, in ancient human skeletal remains in Sudan and Egypt. And antimicrobial agents are present in some herbs that have been used for thousands of years in traditional Chinese medicine. However, antibiotics, as we know them today, were not mass-produced and widely available until World War II. The story goes that in 1920, a British scientist named Alexander Fleming went away on vacation. When Fleming came back to his laboratory, he discovered that he had accidentally left out a petri dish containing staph bacteria. Something in the air, more specifically, a penicillium mold, had landed on the dish and emitted a substance that killed the bacteria everywhere it encountered it. Fleming named this substance penicillin, and over the next 2 decades, other researchers isolated and purified the compound, work for which they won the Nobel Prize. Eventually, penicillin was synthesized in factories and became a life-saving medication during World War II. Infections and injuries that would have previously killed soldiers were now treatable. Antibiotics also made their way into the delivery room. Fatal illnesses such as childbed fever, also known as puerperal sepsis, began to become a tale of the past. Puerperal sepsis or childbed fever is infection from Group A Streptococcus bacteria. It was transmitted from doctors' unwashed hands to the vagina and uterus. And although puerperal sepsis continues to kill women in childbirth in low-resource parts of the world, today it's treatable with antibiotics where they're available. But antibiotics are not perfect. Certain antibiotics are effective at killing only specific bacteria. And some antibiotics, such as penicillin, have a narrow range of action, and others, such as vancomycin, kill a broader swath of bacteria. The ones that kill more bacteria are called broad-spectrum antibiotics. Antibiotics as a medication have side effects. They can cause rashes, nausea, vomiting, diarrhea, and decreased appetite. Broad-spectrum antibiotics like vancomycin have the strongest or worst side effects because they kill off more of the good bacteria in your microbiome. This creates an opening for other microbes to grow and flourish, such as C. diff, a bacteria that's resistant to many antibiotics that can cause life-threatening diarrhea, or candidiasis, a fungus that causes yeast infections. Also, another drawback to antibiotics is some people may develop an allergy after they've been exposed to an antibiotic. However, most adults, up to 90%, who say they have a history of penicillin allergy can actually tolerate penicillin if they take it. This is because the allergy can disappear over time. In other situations, maybe the allergy symptoms you had as a child could have been related to something else, like the original infection. Still, life-threatening allergic reactions called anaphylaxis can happen in some people who are at high risk for a severe reaction. Another problem with antibiotics is that bacteria can evolve to resist the effects of antibiotics. This is called antibiotic resistance. The more often antibiotics are used, the more likely it is that the targeted bacteria will evolve their DNA to become resistant. And antibiotic-resistant bacteria can then spread because it flourishes. Doctors and scientists around the world have labeled antibiotic resistance a global threat, and some have predicted that by the year 2050, without urgent discovery of new antibiotics, 10 million people per year could die from antibiotic-resistant infections. Now, if a strain of bacteria in your body has not evolved to be resistant to a specific antibiotic, then that is called antibiotic susceptibility. For example, Group B Strep, thankfully, is almost always susceptible to penicillin. So what is the evidence on giving antibiotics during labor to prevent early GBS disease? In 1973, a researcher proposed giving pregnant people penicillin to prevent early GBS disease in infants. So researchers tried giving it to pregnant people before labor began, like during the 3rd trimester, but it didn't work. Although penicillin temporarily lowered the GBS levels in the body, by the time labor started at the end of pregnancy, the GBS levels were back up again, showing that GBS grows back quickly once the antibiotic is removed from your system. Next, researchers tried giving antibiotics during labor to those with GBS. In the late 1980s, 3 separate groups of researchers in the US, Spain, and Finland randomly assigned pregnant people with GBS to either receive IV antibiotics during labor, they gave them penicillin or ampicillin, which is a kind of penicillin, or they received no antibiotics. Researchers then combined the data from these 3 studies with a total of 500 pregnant people in a Cochrane review that was last updated in 2014. The results showed that when participants with GBS had antibiotics given to them during labor, the risk of their infants developing early GBS disease dropped by 83%. Now, I want to make a note. Studies with this design, randomly assigning people with GBS to antibiotics or no antibiotics, are highly unlikely to ever happen again, because now with that we have evidence that antibiotics during labor can prevent early GBS disease in newborns, including large observational studies, which I'll talk about in a few minutes. Most researchers would consider it unethical to withhold antibiotics for the sake of research. So these 3 studies from 1985, 1989, and 1991 are probably going to be the last randomized controlled trials we will ever see on this topic. However, as the Cochrane reviewers, Olson and Shaw, wrote, there were quite a few limitations to these 3 randomized trials. In their summary, the Cochrane reviewers said, quote, there is no valid information from these 3 small, old, and biased trials to inform clinical practice, end quote. Healthcare institutions in some countries, such as the United Kingdom, hold the same viewpoint and thus do not universally screen for GBS and treat with antibiotics during labor. However, an alternative perspective would be that there is some valid information from these studies, along with some limitations to the evidence. So how can we interpret the Cochrane Review? Here's the deal. We cite Cochrane Reviews often in our work here at Evidence-Based Birth. The Cochrane Collaboration is a highly respected nonprofit organization that conducts meta-analyses on different topics related to healthcare to help people make informed medical decisions. A meta-analysis is a type of research study where they're pooling or combining statistics from previous studies into one larger study. Now, at the time this Cochrane Review was done, the Cochrane Pregnancy and Childbirth Group has a policy that they only do meta-analyses on randomized controlled trials. So this Cochrane Review on GBS, it was published in 2009 and then updated, but essentially unchanged in 2014, only includes those 3 small trials I already mentioned. And they don't include other types of evidence, such as evidence from large observational or population level studies where some people receive antibiotics and others do not. So the researchers from the Cochrane Review came to strong conclusions against the use of antibiotics for GBS. They really think it's been poorly studied and that this is not an evidence-based practice to give antibiotics to someone who has GBS. And there is some truth to the fact that these 3 studies had major limitations. In fact, most studies published before 1996 had poor quality written reports describing their findings. And that was addressed in 1996 when researchers came together and published something called the Consort Guidelines for Clinical Trials. Basically, it's an evidence-based checklist of items that researchers have to include in their article before it can be published in a peer-reviewed journal. This really forced researchers to be more transparent about their methods and how they carried out the study, and it really improved our ability to evaluate clinical trials. So these 3 studies that the Cochrane reviewers state were invalid were published in 1986, 1989, and 1990 before these Consort guidelines were developed. So this is partially why the written reports of these studies are not up to today's standards. And I'll just give you a few examples of complaints from the Cochrane reviewers, and then I'll give you an alternate perspective. I've got all of these perspectives are going to be in the signature article on Group B Strep, so you can find a table 1 that contains all this info. But for example, the Cochrane reviewers said that none of these 3 trials had a placebo treatment. So they're saying, the antibiotics were compared to no treatment. They should have had a placebo. An alternate perspective from another scientist might be that this would not have changed the findings because the diagnosis of GBS in infants is not subjective. It can't be biased because it's based on culture lab test results. Another problem that they said was that the sample sizes were likely too small to detect differences in early GBS disease and mortality. And an alternate perspective could be that the studies did show a difference in GBS disease rates. And yes, larger studies probably would have been better able to measure something like mortality, but it would take a very large sample. And such a study might not be practical or ethical, given that the researchers found a decrease in GBS disease when antibiotics were given during labor. Another example of the Cochrane Reviewers' critique, in one of the studies, they said that they excluded pregnant people who developed a fever from the statistics, which they thought was an incredible mistake because fever is a risk factor for early GBS disease. An alternate perspective might be, well, that was appropriate. They excluded people with a fever because they needed to receive antibiotics in their case, and they ethically could not be kept in an untreated group of the trial. So, as you can see, there could be arguments made for either way as to how valid these three older trials are. But in summary, although these studies had limitations, which is not uncommon for research published prior to 1996, there is also some valid information from these studies. And we now have newer evidence from large observational studies that kind of confirms what these original trials found. So we're going to talk about that next. So what is the research available from observational studies? In 1996, after those three original randomized trials were published, the CDC in the United States initially recommended two ways to prevent early GBS disease. One, they recommended the universal screening approach, and two, they also recommended the other risk factor approach. Because healthcare providers were choosing to use one or the other approach, scientists in the United States had a unique opportunity to study the effects of these two different methods. So in a study published in the New England Journal of Medicine in 2002 by Schrag et al., researchers used lab results from the CDC and chart reviews to look at more than 629,000 live births that took place between the years 1998 and 1999. Then they randomly selected 5,144 of those births to study, in addition to all 314 infants who were born with early GBS disease. The researchers used hospital records to label people as either receiving the universal screening approach, which was 52% of the sample, or the other risk factor approach, which was 48% of the overall sample. The results? The universal screening method worked better than the other risk factor approach at preventing early GBS disease. Overall, in the entire study, there were 0.5 infants born with GBS per every 1,000 live births. Now, people in both groups, the universal screening group and the other risk factor group, received antibiotics about 33% of the time. But people whose care providers used the universal screening approach had a 54% reduction in the risk of early GBS disease compared to people whose care providers used the other approach. So the findings from this landmark study convinced the CDC to revise their guidelines in 2002 and only recommend the universal screening approach moving forward. Next, in 2003, researchers looked at more than 800,000 births in the U.S. to see whether the new guidelines had been put into practice. Like the previous study, they picked a random sample of infants to analyze, along with all of the babies that did develop early GBS disease, which was 254 infants. Between the years of 1999 and 2002, use of the universal screening approach rose from about 50% to 85%, and use of antibiotics during labor rose from 27% to 32%. This time around, there were 0.32 infants born with early GBS per every 1,000 births. This was down from 0.5 cases per 1,000 only 4 years earlier. When researchers looked at infants who were born at term and had early GBS disease, only 18% were born to those who were not screened. Most of the cases of early GBS disease, 61% of them, happened in pregnant people who had been screened but tested negative for GBS. In other words, the test was a false negative, and they were truly carriers of GBS. The researchers concluded that universal screening and antibiotic use cannot prevent 100% of cases of early GBS disease. To lower GBS disease rates even lower than they were in that study, a community would need easy access to vaccination against GBS. Next, in 2019, a group of researchers led by Nanduri published another analysis of early GBS in the United States and the effects of universal screening. They found that GBS disease has continued to drop. It's now at around 0.23 cases per 1,000 live births. And when they analyzed the infants who had GBS disease over a 10-year period in 10 states, they found the following. In almost half of all cases, there was no medical reason to give the antibiotics. That was because most of these cases had a false negative result. The person was actually a carrier of GBS, but when they tested them at 35 or 36 weeks, they tested negative. In about 22% of cases of early GBS disease, there was an indication for antibiotics, but the antibiotics were not given. So this was a situation for whatever reason the antibiotics were not given. And in 30% of cases of GBS disease, the birthing person was tested, found to be positive, given the recommended antibiotic, but the baby still developed early GBS disease. And most of these cases happened in babies that did not receive at least 4 hours of antibiotics, which we'll talk about in a minute. In a meta-analysis published by Russell et al. In 2017, they combined data from 30 studies around the world with more than 20,000 births, and they compared rates of early GBS disease in locations where A, there is no policy or method used to prevent GBS disease, or B, there is a policy of universal screening and treatment with antibiotics as needed, with varying levels of implementation. It's not always implemented correctly. They found that in places around the world where there is zero policy for GBS disease prevention, which is common in low-resource countries, the risk of early GBS disease if the birthing person is a GBS carrier is about 1.1%. In settings where there is a policy of universal screening for GBS, and if antibiotics are given correctly at least 75% of the time, the risk of infants experiencing early GBS disease was 0.3%. And these percentages line up with what was reported in the original randomized trials on Group B Strep prevention. I mentioned receiving at least 4 hours of antibiotics. So what is the best timing to receive antibiotics for GBS? So as I mentioned earlier, a percentage of cases of early GBS disease do happen even though the birthing person received antibiotics. It was about 30% of all cases of GBS disease. But in most of those cases, the antibiotics were not given at least 4 hours before the baby's birth. Other researchers have had similar findings that 4 hours or more of antibiotics is the most effective way to prevent early GBS disease. A study carried out by Fairley et al. Found that when penicillin or ampicillin is given to someone who's GBS positive more than 4 hours before birth, it's effective at preventing early GBS disease in the infant 89% of the time. In contrast, giving antibiotics 2 to 4 hours before the birth is effective only 38% of the time. And antibiotics given with even less time, less than 2 hours, are also not as effective. When clindamycin, which is a different antibiotic, is used instead of penicillin, it works very poorly and only is effective 22% of the time. Now, that's not surprising because many strains of GBS are highly resistant to clindamycin. In a study in Uruguay, published by Scasso et al. In 2015, researchers followed 60 carriers of GBS at term who came to the hospital in early labor. They swabbed each person for GBS before antibiotics were started, and then again 2 and 4 hours after the first dose of penicillin was given. The researchers found that 72% of the participants were GBS positive right before antibiotics were started, 47% were still positive 2 hours after the first dose, and only 12% were positive for GBS 4 hours after the first dose. In all 60 newborns, the cord blood and amniotic fluid reached therapeutic levels of penicillin, even though 28% of the women gave birth before 4 hours. The maximum effect of the antibiotics was reached at 4 hours, just before the next dose of penicillin was due. Because it takes time for antibiotics to pass from your blood to the fetus's blood at therapeutic levels and kill off GBS bacteria, it makes sense that giving the first dose of antibiotics too late, for example, just a few minutes before birth, might not help to stop a GBS infection from growing in the fetus. Based on research evidence, ACOG recommends that antibiotics for GBS should be started at least 4 hours before birth. However, they also state now that medically necessary interventions should not be purposefully delayed just to get the 4 hours of antibiotics in. And although 4 hours or more of antibiotics is ideal, 2 hours of antibiotics can still provide partial protection against GBS disease. But how do these antibiotics given during labor to the birthing person affect the newborn's microbiome? Towards the beginning of this podcast, I talked about the importance of the microbiome and how it is seeded at birth. Unfortunately, antibiotics don't just affect the bad bacteria that they are targeting, they also impact other bacteria, including good bacteria or the probiotics. When I first started publishing about Group B Strep back in 2014, there was zero research on the microbiome effects of in-labor antibiotics for GBS. But since that time, researchers have started analyzing this topic. We now have at least 2 meta-analyses and 9 individual studies on the microbiome consequences of IV antibiotics during labor for Group B Strep. So in our updated article on this topic, we have 9 studies we've reviewed in Table 2, where researchers enrolled infants who were exposed to antibiotics during labor, typically for GBS, as well as infants who were not exposed to IV antibiotics during labor. And most of the researchers studied the infant gut microbiome. They collected and analyzed bacteria in their stool samples at different time points, ranging from 2 days of life to 1 year of age. Overall, researchers consistently found that receiving IV antibiotics during labor negatively impacts the infant's microbiome, at least temporarily. 8 of the 9 studies found that IV antibiotics during labor had at least a short-term effect on reducing beneficial bacteria or increasing levels of non-beneficial or potentially harmful bacteria. Of the 5 studies that followed the infant microbiome over time, 2 of them found that the infant's microbiome had either recovered or mostly recovered by 8 weeks, while 3 other studies found important differences that persisted up to 3 months or even a year later in some infants. The most important study on this topic, and the only one to study infants for at least a year, was carried out by researchers in Canada, published by Azad et al. In 2016. So infants were included in this study if they had stool samples collected at 3 months and 1 year, and they also had to have complete information about antibiotic exposure during labor and during infancy. So they divided these infants into 4 groups. The first group was no antibiotic exposure during labor, and the babies were born vaginally. The second group was antibiotic exposure, and they were born vaginally. The third group was antibiotic exposure with an elective cesarean, and the fourth group was antibiotic exposure with an unplanned cesarean. Cefazolin was the antibiotic that was typically used during cesareans, and penicillin was the antibiotic of choice for vaginal births. Researchers also measured the presence and length of exclusive breastfeeding or chest feeding. The results showed that the infant microbiome was influenced by antibiotic exposure during labor. It was also influenced by the birth route, either cesarean or vaginal birth, and by whether or not the baby was breastfed or chest fed. At 3 months of age, infants who were exposed to antibiotics during labor or birth had a decreased level of beneficial bacteria, as well as a decrease in the richness of their microbiome, regardless of whether they were exclusively breastfed or not. The most severe deficiencies in the microbiome happened among infants who were born by cesarean. Infants born by cesarean also had higher levels of Clostridium, Enterococcus, and Streptococcus, which are potentially harmful bacteria. Now, encouragingly, by 1 year of age, most of these differences were gone, showing that antibiotics only have a short-term effect on the infant microbiome. However, some negative effects on the microbiome persisted in infants born by unplanned cesarean who had not been breastfed or chest fed for at least 3 months. And other researchers have cautioned that temporary changes in the microbiome during that first year could still have a negative long-term impact on the developing immune system. Now, the changes in the infant microbiome that we're seeing in all these studies are consistent with what you would expect after giving IV antibiotics like penicillin and ampicillin that mainly act against the type of bacteria called gram-positive bacteria. Killing off gram-positive bacteria like Group B Strep can lead to an overabundance of gram-negative bacteria. Also, some beneficial probiotics like bacteroidetes are sensitive to penicillin and ampicillin, meaning that they are killed off by these antibiotics. So in summary, it does appear research shows that IV antibiotics during childbirth can have a short-term negative effect on the infant's microbiome. This negative effect can be lessened by vaginal birth and breastfeeding or chest feeding. And we still need research to find out if there's any long-term immune effects associated with the temporary reduction in beneficial bacteria. I also want to point out that if parents receive antibiotics and have a cesarean, or they receive antibiotics and they choose not to breastfeed or chest feed, they may need support from their care provider in using other methods such as donor milk, probiotic supplementation, or formula that has probiotics to help their baby recover from any negative microbiome impact from antibiotics. So what are the potential benefits and harms of the universal screen and treat approach that we use here in the United States, and it's used in many other countries as well? Well, the potential benefits include the fact that in clinical trials and observational studies, giving antibiotics, penicillin or ampicillin, to someone who's a carrier of GBS during labor decreases the risk of GBS disease. Penicillin and ampicillin rapidly cross the placenta into fetal circulation at non-toxic levels and can prevent GBS from growing in the fetus in most cases. And in a large observational study where they were able to compare both approaches, the universal screening approach was associated with lower rates of early GBS disease than giving antibiotics based on other risk factors. And most researchers have encouragingly found that antibiotic resistance from GBS has not been a problem with penicillin. But what are the potential harms? Although rare, it is possible to have a severe allergic reaction to an antibiotic in a birthing person. The last time it was studied in the 1980s, the risk of a severe reaction to penicillin was estimated to be 1 in 10,000 and possibly 1 in 100,000 for a fatal reaction. It's now recommended by ACOG that pregnant people who are at a risk for severe penicillin allergy receive skin testing, which is considered safe and beneficial and will help you determine if you have an allergy to penicillin or not. Also, IV antibiotics have a short-term negative effect on the infant's microbiome. Whether or not this translates into any long-term health outcomes is still unknown. We do know that the antibiotics' negative effects on the microbiome can be lessened by human milk and through vaginal birth, but that's not always possible in all cases, as we know. Also, because antibiotics can kill off good bacteria as well as bad bacteria, antibiotics increase the risk of yeast infections or fungal infections, which thrive in the absence of good bacteria. So yeast or fungal infections known as candidiasis can harm the breastfeeding-chest-feeding relationship. That's because with a dual parent-infant yeast infection, the postpartum person may develop red, painful nipples that are infected with yeast, while the infant may experience thrush, which is yeast in the mouth, where the mouth becomes inflamed and painful. And in one study, the rate of parent-infant yeast infection was 15% in those who had antibiotics during labor compared to 7% who did not use antibiotics. Other potential harms related to this universal screening and treatment approach have to do with the side effects related to each individual antibiotic. And in our article, we will have links where you can learn more about the side effects of penicillin, ampicillin, cefazolin, clindamycin, and vancomycin. And then finally, antibiotics contribute to the medicalization of labor and birth because of the need for early hospital admission to ensure that you get the 4 hours or more of antibiotics, the need for IV insertion and IV medications and fluids to deliver the medication. One more thing before we go, I do want to talk just briefly about the best antibiotics for someone who is allergic to penicillin. As I mentioned earlier, most adults who report having an allergy to penicillin are actually no longer allergic to penicillin because you can outgrow this allergy, or it might not have been a true allergy in the first place. However, some people remain at high risk for severe allergic reactions. In their latest guidelines on GBS, ACOG provides a flowchart that helps people determine which antibiotics should be used for GBS in cases where there's a suspected penicillin allergy. So the strategy that ACOG recommends includes, during a prenatal visit, discussing any past allergic reaction to penicillin. And if the history indicates that you have a low risk of penicillin allergy, then you can receive cefazolin instead. Now, it used to be taught that about 10% of people with a penicillin allergy would be cross-allergic to cefazolin, but now we know that's much less common. It's around 1 to 4%. So most people who are allergic to penicillin can tolerate cefazolin, and cefazolin is a good option. It's effective against GBS. Another option is you could undergo skin testing to determine if you have a true penicillin allergy or not. If the history indicates that you are at high risk for a penicillin allergy, then your third trimester GBS culture should test for clindamycin susceptibility. If the strain of GBS that you carry is susceptible to clindamycin, then clindamycin can be given during labor. If the GBS strain is resistant to clindamycin, then vancomycin can be given. And then again, another option would be to do the skin testing to see if you have a true penicillin allergy. If you have an unknown risk of allergy to penicillin, for example, you're not sure if you're allergic or not, you can have skin testing, you could take cefazolin, or you could have the culture testing to see if you need clindamycin or vancomycin. As a side note, ampicillin is a type of penicillin, so if you're allergic to penicillin, you can't take ampicillin. Now, as you might have noticed from me kind of explaining these guidelines, most people who have an allergy to penicillin can take cefazolin, and one advantage to cefazolin is that, like penicillin, it crosses the placenta, it reaches the fetal bloodstream, it has a narrow range of action, so it's not as harmful to the microbiome, and actually it can be given every 8 hours instead of every 4, which can be convenient. If you can't take penicillin, ampicillin, or cefazolin, the two alternate options, clindamycin and vancomycin, have never been tested in clinical trials for the prevention of GBS disease. Clindamycin faces high rates of drug resistance, barely reaches the fetal bloodstream, and should never be used unless the GBS strain is shown in culture testing to be susceptible to clindamycin. Vancomycin is a broad-spectrum antibiotic that attacks many different types of bacteria. As a result, it has more frequent side effects, more serious side effects, and a larger impact on the microbiome. Also, overuse of vancomycin increases the risk that our communities will develop antibiotic resistance to vancomycin. And its serious potential side effects mean that there must be safety protocols in place, such as giving it slowly over 1 to 2 hours at minimum, checking your kidney function before they give you the drug, and using weight-based dosing, meaning they base how much dose you get on your actual weight. Unfortunately, the American Academy of Pediatrics does not consider clindamycin or vancomycin to be quote-unquote adequate prevention of early GBS disease, which sometimes means more newborn monitoring might be recommended. And we will talk more about that in part 2. So I hope you enjoyed part 1 on the evidence on Group B Strep. In part 2, which will come out on March 1st, 2023, that will be episode 257, we will cover alternatives to antibiotics, including hibiclins, garlic, vaccines, probiotic, human milk, and more, and whether or not there's any evidence to support those alternatives. And we're going to do a ton of frequently asked questions about self-testing, rapid tests, options for getting unhooked from the IV, multiple tests, monitoring babies, signs of GBS in infants, how GBS affects different communities, a sample of national guidelines, and we'll end with our bottom line on GBS. Don't forget to subscribe to our newsletter on our homepage in order to be notified when the GBS handout comes out. And if you're listening to this March 1st or later in 2023, you can find all the info and handouts at ebbirth.com/Group B Strep. Thanks everyone, and I'll see you next time. Bye. Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasebirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.